Thank you, Dr.
Well, thanks everybody for coming. I'm going not going to stand up here and regurgitate a bunch of recent literature, experimental stuff, or things like that. But I'm going to talk about things that either I get questions about or concerns about from docs, midwives, nurses, all the provider side, or the PNFPs hear about from the same group of people as they deal with hypertension and pregnancy. Okay. So this is the latest World Health Organization data about causes of maternal mortality, and you can see hypertension is number 2 behind hemorrhage. And we can say that this is World Health Organization, so this is covering all the third world countries and places that don't have health care, and surely we can't be that bad. But the reality is not really that good. We are a little less than 18%, but our rate of hypertension in pregnancy has increased dramatically in the past 20 to 30 years. This is probably 30 years now. But there still are a significant number of maternal deaths related to hypertension in the United States. And these 2 articles at the bottom looked closely at those maternal deaths and estimated at least 30% of them were very preventable. Okay, probably more than that, but at least 30% were very preventable. And that for every one of those deaths, there was probably another 50 to 100 near misses that caused significant maternal morbidity, placental abruption, prolonged hospital admissions, organ damage, seizure activity, necessitating intravenous medications for severe hypertension. Those kind of things were included in the morbidity data. So there are a lot of potential problems if we don't pay attention to blood pressure and hypertension. And those 2 articles brought out 3 things as the most common causes of morbidity that should have been preventable. And those, you can see those there. Failure to treat the hypertension being number 1. Okay, of course, attributing proteinuria to UTI. Pretty rare in UTI to have 2 to 3 plus, 4 plus protein in your urine. Happens to have lesser degrees, but not that much. And then right upper quadrant pain from health syndrome being attributed to something else. Gallstones, what have you. Gallstones, cholecystitis, those kind of things are not nearly as common as preeclampsia is in a pregnant woman. And so preeclampsia should be ruled out first before we start doing all those other things for patients. So this is where I'm going to get a lot of quotes. This is really recent, January 2019. ACOG put out a new, they call it practice bulletins now. When I started, it's called technical bulletins. Dating myself. Practice bulletin 202, January 2019. And most of you guys are like me when you read ACOG stuff. I'm like, okay, commit to something. Tell me something. Dude, what do I do? This is one area where they actually do this. Don't not do this. They really lay it out. Here's what the best evidence is. It does give you that at the end, but this is just a guideline. Individual, patients can be done different ways and stuff like that. But it really lays it out. Do this. And I think it's when that happens, we should be really paying attention to that. So we know from residency and training that preeclampsia, the pathophysiology, is an endothelial dysfunction, that the resistance suppressor agents that the vasculature of a pregnant woman shows disappears for some reason in preeclampsia. They get back to where that the endothelium is very reactive to presses. And it results in a vasospastic situation where the vessels are constricting down, and periodically will also spasm even tighter, so that if we traced our blood pressure continuously on preeclampsia, we would be able to watch those peaks where the spasm is occurring. And there is no time that the spasms occur. It's not like every 5 minutes or every 5 days. It's very different from person to person when that was looked at. That spasm then leads to ischemia of varying organs, liver, kidneys, brain, basically anywhere, and decreased blood flow to the uterus, so that you get introducing growth restriction in the baby. Unfortunately, the etiology is still unknown. There's a lot of evidence currently pointing to the placenta, the implantation of the placenta, but still we don't really know what happens with that. It's creating some bad, protein or hormone that is released into the system to cause all this to happen. So it's still a little bit confusing in terms of that and finding a cure, I guess, for preeclampsia. Now, we all know the diagnostic criteria: blood pressure, proteinuria. The severe criteria are listed at the bottom. One thing to remember is that blood pressure, okay, it does say up there, I'm not sure, there it is, at least 4 hours apart. Okay? Well, when you have somebody that's got a blood pressure of 180 over 110, giving them 4 hours to correct it so you can see if they really have preeclampsia is probably not in the best interest of your patient or your well-being either. And so here with the severe range blood pressures, it says you can confirm this in a much shorter interval to facilitate timely antihypertensive therapy. Proteinuria, used to always think that you must have proteinuria. In fact, preeclampsia started out being called proteinuric hypertension. And that we found lately that no longer is the case. You can see high blood pressure, you can see all these other severe problems without significant proteinuria. And so proteinuria is not mandatory for the diagnosis anymore. As you can see there, so you can see in the absence of proteinuria, hypertension, and these other things. This is the chart from that article that I showed you, and it does leave off right upper quadrant pain, which it does discuss in the article. So the right upper quadrant pain is a marker for severe disease. You do not have to have elevated liver enzymes with your right upper quadrant pain. The elevated liver enzymes come from the ischemia of hepatic cells. And if you don't have ischemia but have subcapsular edema, you're going to get pain. So you can have one without the other. Gestational hypertension, diagnosis, this is good. Hypertension without proteinuria or severe features developing after 20 weeks, and blood pressure levels return to normal in the postpartum period. So that tells us right out of the bat we can't really diagnose gestational hypertension until the lady's done with her pregnancy. And we see that her blood pressure goes back to normal. So it's really more of an exercise in what do we want to call this, more of a nomenclature problem, and not one of differential diagnosis. The notion that gestational hypertension is intrinsically less concerning than preeclampsia is incorrect. Both of them can get worse. Both of them progress to severe disease. Both of them can result in eclampsia, strokes, and significant issues. And any time that I quote something directly from the article, I'm going to put quotes around it. Everybody understand that it's not just me getting on my soapbox, it's all of you seeing me on my soapbox. These two in red are even more significant from the article for gestational hypertension. And basically what each of them says is that gestational hypertension, whether we can't call it mild anymore, but gestational hypertension without severe features or gestational hypertension with severe feature, and that severe feature being blood pressure, both of them should be treated as though they were the equivalent preeclampsia level. Okay, so that means delivery, MAG, antihypertensive medicine, all those things you would do for a preeclamptic woman, you ought to do for someone who just has hypertension. And then eclampsia, fortunately for all of us, preeclampsia doesn't always progress to eclampsia. Neither does severe preeclampsia. It would be false to consider that to always be something that happens. These are two studies out of the UK that suggested that preeclampsia without severe features will go to eclampsia in about 2%, and with severe features, a little over 3%. I've seen numbers from the U.S. that are about equal to the first one, the 2% one. and a little bit higher for the severe one, about 4 to 5%. But it's all right within that ballpark. Unfortunately for us, it doesn't happen all the time. And with that in mind, we want to make sure that we're not lulled into thinking, oh, it just won't happen. It just doesn't happen. I haven't seen one of those in 20 years, or whatever. So we've got to remember that it's always out there, that we need to be treating appropriately to try to prevent eclampsia as much as we can. Now, can we predict when it's going to happen? No, absolutely not. There are things that make you more concerned about cerebral irritation, obviously persistent headaches, blurred vision, photophobia, altered mental status. DTRs, we used to always think, ooh, really hyperreactive DTRs, but younger women have pretty hyperactive DTRs. You get 3 or 4 plus out of somebody who has low hypertension some of the time. So be careful with the DTR part. Clonus probably a little more significant as well, but there's a real recent review here that I kind of found, I think it's about a month ago, that basically came to the conclusion that of the most commonly reported symptoms, none were able to accurately predict nor rule out imminent eclampsia. So we can't just say, oh, she's not going to get it because she doesn't have a bad headache, so I'm not going to get MAG. Probably not the best action to take. All right, so management. Gestational hypertension or preeclampsia without severe features. Once you identify this patient, they are at risk to progress. Not all of them will, of course, as we saw earlier, but they are at risk to develop severe preeclampsia or eclampsia. So we need to increase the observation of this patient. Outpatient is considered safe and appropriate in patients with milder disease, but probably ought to have at least twice weekly evaluations, both blood pressure and symptomatology, so interviewing the patient to see what's going on other than just blood pressure. They have weekly labs. You don't need to recheck the protein because we no longer use protein to determine the severity. So once you know they have the proteinuria, you don't need to continue to measure it as you go forward. Once or twice a week antepartum testing. They suggest that at least you have a weekly AFI to look up, because AFI is fairly sensitive to uteroplacental dysfunction. So probably a BPP once a week or a BPP twice a week is fine. Delivery at 37 weeks, and what I like here is that they put this other stuff in the absence of preterm labor, ruptured membranes, of course abnormal testing, or vaginal bleeding. If you got too many problems going on, be done. That's basically what it's saying to me, is if you got too many things happening, be done. And the reason for 37 weeks is that there are several studies, this being one of the bigger ones, Lancet, that show that expected management beyond 37 weeks then tips into the point of significant morbidity for mom, health syndrome, things like that. So 37 weeks for anybody with mild preeclampsia without severe features or gestational hypertension. So with severe features, in gestational hypertension, the only severe feature is going to be blood pressure. But expectant management is acceptable, provided mom and baby are stable. And it's acceptable only when the severe criteria is hypertension, and you can control it. If you can't control the hypertension with medications, then you need to deliver. And ACOG suggests that in-house is the only place to do this. That's because there's such a dynamic disease process going on. It can change quickly, it can never change, and predicting who is going to do that and to what degree is absolutely impossible. So being in the house where you can monitor blood pressure throughout the day, monitor the baby every day, make sure that things are staying stable is the place to do that. And then deliver at 34 weeks, again, without deterioration, status, ruptured membranes, or preterm labor. Too many problems. It's harder to deal with, the more bad things happen. Give these people steroids, but don't delay delivery for steroids in people that need to be delivered. Don't take a risk with mom or baby. If mom has a stroke and dies, there's no benefit to having given the baby steroids. That's pretty hard to argue. Clamp for stabilize mom and baby. Magnesium is primary anti-seizure medication. Antihypertensive medication is needed and then delivered. The clamp, to make it very clear, eclampsia is not an indication for cesarean section. In fact, somebody who's having a clamtic seizure oftentimes would be induced much more easily than they would have without the eclamptic seizure. But it's always better for someone with a significant medical or complicated issue to undergo a vaginal delivery because of all the blood loss and all the things that go along with the stresses that go along with C-section, if possible. This kind of when I was putting this together, it kind of reminded me of when I was and everybody always has little whimsical things to say. My resident program always used to say, stop the pit, and start the pit. That's just the way you treat it. So seizure prophylaxis, I mentioned magnesium is superior to other meds. There are numerous studies looking at Dilantin, phenobarb, what have you, and magnesium works better. Using magnesium in mild preeclampsia is a difficult topic. It's difficult because there's not really a good consensus out there about what to do. Give it, not give it. Granted, the rate, as we saw earlier, of eclampsia is going to be less in people with non-severe disease, but it still happens. And the only randomized trials, there are 2 of them, that looked at 357 patients. And the conclusion that ACOG makes, while they don't say you don't need to give it in mild, they only say you need to give it in severe. So we've extrapolated that to mean, okay, we don't have to give it in mild. It's not really what they're saying. This is the direct quote. Given the small sample size, the results of these studies cannot be used for clinical guidance. If we are doing that, and not giving it. But if you choose not to give magnesium in mild preeclampsia or gestational hypertension, certainly if anything changes during the labor process, if you get a high blood pressure, you have to give Betalol IV. You now have severe disease, and you should put them on magnesium. If they get bad headache, you now have severe disease, you should put them on magnesium. Okay. Severe disease, unless there's a medical contraindication of MAG, it should be used in all of these cases. And the only real contraindication I know of is myasthenia gravis. Okay, because it affects the muscles significantly to give MAG. Renal failure is not an indication not to give MAG, it's an indication to change the dose because they don't need as much, they can't clear it as quickly. So that's not an indication to hold MAG. Now, if a patient says, I'm not taking that stuff, my mom had it, she said it was the worst stuff in the world, or my sister had it, what have you, you can't make anybody do anything, but that needs to be documented very clearly in the chart, that you advise this patient to take the magnesium, risk and benefit, she refused, so it's not going to be done. Not documenting that and then having a problem will come back to be an issue, of course. Best loading dose is 6 grams. This isn't in quotes, so this is coming from me. There is some data, one statement by SPY looking retrospectively at doses of magnesium 4 gram versus 6 gram load. And the 6 gram load consistently reached that 5 to 8 milligrams per deciliter level that you want, whereas the 4 gram load did not. Same thing, there was a study looking differently at preventing seizures on Parkland, and the lead up into starting that study was to see how much MAG they needed to give to make sure that they had appropriate levels, and they never got an appropriate level with 4 gram load. So they recommended always using a 6 gram load to get started with your MAG. If you're going to do expected management for severe preeclampsia, you have to have them on MAG to get your evaluation done, which is totally appropriate. You can stop that once you've made the decision to manage expectantly. You can stop the MAG. Leaving somebody on MAG for days, weeks at a time is nasty. They don't like it. They won't like you for very long. then one thing that I want to stress that I see a lot of, and I'm asked by anesthesiologists almost routinely if I do a C-section on a preeclamptic woman that's on MAG, is do you want to stop the MAG? No, I don't want to stop the MAG. We should not stop the MAG. ACOG comes out and actually says that women with C-section should be on their MAG during the surgery, before, during, and after the surgery. There is some suggestion that the stress of surgery might lower the seizure threshold in some of these women, and there might be more seizures. There's also concern that if you have to use general endotracheal anesthesia, that might raise or lower the seizure threshold as well, and having these women off of their MAG may increase their chance to have a seizure. So, MAG during the C-section. Antihypertensive therapy. Our goal of therapy is to prevent these issues from happening here. Big one being a hemorrhagic stroke. Anybody's ever had one happen to them? I've had one. Won't ever forget it all your rest of your life, especially if the woman doesn't survive. It's tragic. Any severe hypertension, that's defined as systolic blood pressure 160 or more, diastolic blood pressure 110 or more. That is not and, that is or. Okay? Either one. Persistent for 15 minutes, it'll take that long to get the IV medicine out of the Pyxis into the patient's room, so if you get another blood pressure and it's down, you can go ahead and hold the medicine. But I would tell you that keep it in your pocket because it's going to come back up at some point. ACOG thing, as we saw earlier, is to administer the antihypertensive therapy just as soon as you can. You all know the med for Begalol hydralazine intravenously or for cardiac PO. We have a great hypertensive protocol which is adapted from the ACOG, A1, SMFM, all their recommendations about how to treat acute hypertensive crises during pregnancy. So I would recommend if somebody calls you and have one to follow. PO, Begalol, does not work as fast. It takes time. PO for cardio works pretty quick, and you don't need to break it under their tongue as we used to do. You just swallow it, it dissolves really rapidly, and is absorbed very, very quickly. Begalol does not absorb that quickly. It doesn't take time to work orally. So if you have a crisis, that severe blood pressure, you should give it IV. Inconvenient for everybody, yeah, I understand, but it's the way to go. And this is just kind of emphasizes that a little bit. This is a study that came out of UAB, where I think we're looked at 28 women with a stroke. 12 of them were antepartum, 16 were postpartum. First, that tells you that you're not out of the woods once you deliver the baby. Of the ones that were monitored at the time of their stroke, so some of these, there were 24, so 4 of them came in after the stroke had happened as an outpatient somewhere. You can see the systolic blood pressure is very, almost always elevated prior to the stroke. Diastolic blood pressure not nearly as often, 3 out of the 24. And you see it's not that high. We might, our ED colleagues will look at 175 systolic blood pressure in an 80-year-old person's head. We'll give them another tablet of their whatever they're on. And I talk to them. We have a different population. Young pregnant women or reproductive age women haven't been, most of them have not had chronic hypertension for years and years. Chronic hypertension, as a lot of you know, causes the intimal layer of your blood vessels to thicken so that they can withstand that pressure and not burst, not cause a stroke, basically. And our women don't have that. And the other unfortunate thing is there's no way to tell if they have chronic hypertension. Do they have it? So you still have to treat them. You can't say, oh, she's got chronic hypertension, I'm not going to treat until she's 180, because it'll bottom the baby. And yes, might do that. That's pretty rare. But so any pregnant woman, we should be treating once they get with medications once they get a severe range of blood pressure, even if they're chronically hypertensive. And the worst part of this is half these women die. So not a good thing. get on top of it. Your one will live with you forever and ever and ever as it happens. So, prevention, prophylaxis against worsening preeclampsia, bed rest. We used to always, when I was in training, bed rest was the deal. You got preeclampsia, you went to bed, you laid down and stuff. There is absolutely zero evidence to support that as being able to prevent or treat preeclampsia in any way. And it's probably more harmful in terms of risk of DVTs, having to change your lifestyle, not being able to take care of the kids that are around, things like that. The people just don't have resources to sit in bed. Aspirin. Aspirin's a good one. Everybody knows that aspirin is a benefit to at least decreasing the incidence of recurrent preeclampsia. I alluded earlier that we lose the vascular resistance in people with preeclampsia, and therefore their vessels constrict down and hypertension. That's been documented to be because there's an imbalance of prostacyclin and thromboxane A2. Prostacyclin being a potent vasodilator, thromboxane being a potent vasoconstrictor. And when you give low-dose aspirin, the common pathway that goes from arachidonic acid to these two prostaglandins is driven by cyclooxygenase. And low-dose aspirin preferentially blocks the pathway to thromboxane more than it blocks the prostacyclin. So you shift the ratio of thromboxane to prostacyclin in favor of vasodilation. So you can decrease the incidence of preeclampsia. As we know from our reproductive endocrine guys, they put all these people on aspirin when they do their IVF and stuff. So maybe it also, when you started early enough, has some effect on the placenta, because we're getting all this research now that says placenta is somehow a causative factor in preeclampsia. Maybe it helps with placental implantation. But aspirin will reduce or will shift that ratio. This is a very one of the bigger meta-analyses looking at aspirin. And interestingly enough, what it showed is that if you start your aspirin before 16 weeks, that you get a bigger effect in reducing preeclampsia. It had some significant reduction in severe preeclampsia and a reduction in growth restriction babies. Again, maybe something with this as well. But if you can, try to start before 16 weeks. Now, other questions about aspirin. 1 or 2 of them every day. There's some really recent stuff that says if you have more than 150 milligrams of aspirin a day, you get a better, and you start it before 16 weeks, you get a better effect. Which is why you'll see stuff come back to me that says, I asked her to go ahead and take 2 instead of 1, because I thought she was at a significant risk. Now, who is at risk? Well, if you look at I didn't put it in the chart. But if you look at some of the charts, like from the U.S. Preventive Services Task Force, everybody's at risk. The only person that's not at risk is somebody who's had 1 previous term uncomplicated vaginal delivery. But if they get a new husband, now then they're at risk. So basically, everybody's at risk. So these are still questions to be fully answered by some good research, which isn't out there for them. But I think, honestly, we may get to where everyone should be on at least 1 baby aspirin every day. So let's talk a little bit about postpartum. Postpartum hypertension and preeclampsia. I don't know what everybody else thinks, but I think we're seeing a lot more of that. And I don't know if there's really more, or if we're now more attuned to it, because we're getting more attuned to hypertension anyway. But boy, it seems like every week there's 2 or 3 people come in and they're in postpartum, 3 days, 5 days, headaches, severe pressures and stuff. We do often see a blood pressure increase in 2 to 4 days postpartum, particularly in people that have been hypertensive during their pregnancy. Okay, now is that related to a further change in that vascular resistance? Maybe they were hypertensive, but there was still some resistance to their vasculature pressors, and now that their pregnancy hormones and what have you, whatever causing this problem, are getting out of their system, they get more normal quicker because they don't have to start to drop back to normal. So you see a vasoconstriction. at that 2. I don't know the answer to that. That's just a thought.
Coming off May, that's
MAG's not an antihypertensive.
But when it comes off May, you need to...
They do get more irritable when they're off, when they come off MAG. I think people get more, they've been just kind of, I'm just going to lay here. And all of a sudden they're up, they're doing stuff, but we need to be pretty aware of that, and a lot of people are making the recommendation now that we should have a postpartum visit at like day 5, postpartum day 5 to check blood pressure. But at least, if not doing that, we should provide some pretty significant education for patients when they come home, particularly those that were hypertensive before delivery, symptoms, when to call, when to go to the ED, things like that. And I think there's also room for education for providers in terms of when I get a call at 10 o'clock at night and the lady's got a headache. Do I tell her to take a couple of time off, go to sleep, call me in the morning, or do I say, maybe you ought to go in and get your blood pressure checked? And finally, I think this is the last part, non-steroidals, aspirin, or Motrin, stuff like that after delivery. Of course, they're preferred over opioids. I don't know how many of you remember, it's probably been 15, 20 years, we weren't given enough opioids. We weren't controlling the pain. Now we're on the other side. There's way too many, and it's kind of look back. But nonetheless, I agree the opioid epidemic is terrible. But anyway, we prefer to give non-steroidals over opioids for pain control if we can. The idea behind them and being a problem is that they affect prostaglandin. So again, you're affecting that thromboxane-prostacyclin ratio, and you may cause a lack of vasodilatation or dilation and result in hypertension. Now, that's the idea, and that probably happens in older people a whole lot. But there's a good RCT here came out in 2018, so about a year and a half old, between ibuprofen and acetaminophen in people with severe preeclampsia. And as you can see, the conclusion was that ibuprofen did not link the duration of severe range of blood pressure. So it didn't really affect the blood pressure in unhealthy men. Those underlying processes of preeclampsia that cause the blood pressure issue. And overall, data supports the safe use of non-steroidals in postpartum patients with blood pressure issues. That's the quote from ACOG. Now, they do go on to suggest we've got to consider watching people that have chronic hypertension closer because they may have a different or an additional pathology going on. They may get some effect from the non-steroidal, but they make no suggestion that we should avoid them in people with chronic hypertension. So here's the 2 great resources that ACOG's put out recently. Well, I didn't go into chronic hypertension to any great degree. That's another talk. But both of those are very good. They're very specific. Do this, don't do that kind of thing, which is not usual for them. So when it comes out, it kind of makes me wake up a little bit and say, wow, maybe this is something we really should be paying attention to. Thank you.
That's amazing. Thank you.
Questions?
I do. I think there's some questions that I've had from docs. So when we're delivering at 34 weeks for severe preeclampsia, in your opinion, is it reasonable to deliver at 34.2 or 34.0? Is there a real big difference?
If you have somebody that's been well controlled, I think 1 or 2 days either side is not going to make a difference. It might be more convenient to deliver on Monday than on Saturday, but I don't think 1 or 2 days, provided the control is good, that's going to make a big difference.
The other question is postpartum blood pressure management. So I know we don't use MAG for blood pressure, but we do see blood pressures rebound off of MAG. So I think one of the concepts you should consider is they may need more blood pressure medicine after delivery than prior to delivery. And so we don't need to, we don't need to worry about the fetus anymore. So we can be pretty confident government with prescribing higher doses of blood pressure medicine, right?
Agreed.
And I think sometimes, they're on the beta level 200 and we'll go up to 300, and that's probably not adequate for postpartum. The other comment was about women of color typically respond to Procardia XL better than labetalol. And we do see that. I don't know if that's studied.
There's a study on that.
Is there? It's also observational in our practice. And so, we don't often use MAG and Procardia together, but you can use them together.
Yeah, the MAG and Procardia thing, I'll just put that out there, is thought that you give the heart basically a double dose of inhibitor. That's not ever been shown to happen in pregnant women. People have looked at that. It was just a theoretical thing, like lots of theoretical things that arise, mostly out of elderly people. I don't know how many of you remember when we couldn't get hydralazine on labor and delivery, they had to go to the unit because it causes a rebound tachycardia. 80-year-old person with a heart rate of 120 has a heart attack. And so everybody was getting put on heart monitors to get hydralazine. When young healthy women tolerate a heart rate of 120, no problem. So we do make a lot of, at times, a lot of assumptions based on lack of data, theoretical assumptions.
What is your indication for when patients come back in after they've been treated for hypertension, delivered, 3 days later come back in and high blood pressures, maybe were monitored or treated about magnesium and sperm?
Yeah, there's very little to help you with that up there. My first thing is if somebody comes back and wasn't on MAG, I couldn't run MAG. I'm going to consider this to be new. Okay? If somebody was on MAG and they're just having elevated blood pressures, I'll treat that. If somebody came in, they were on MAG for their elevated blood pressures, and now their liver enzymes are up, they're back on MAG because it's progressed, gotten worse than it ever was before. Just kind of a personal thought. There's not really data, good data to drive this one this way, this one this way. Unfortunately. And I agree with the more aggressive blood pressure medication or dosage. Postpartum is, if you go from 200 twice a day from a big level, 300 twice a day, you haven't made much difference. Just go to 200 to 400 to 3 times a day. And if you go to 3 times a day, sometimes we decrease that. We'll be at 400 twice a day. We decrease it to 300 3 times a day. I would just go to 400 3 times a day. Thanks.
Thank you. Okay, thanks so much. Let's see, Laura or Eric, you want to help out?